Hello, everybody. Welcome to our webinar today that's been organized by Polarean on lung imaging with xenon MRI in children and building a successful clinical program. My name is Kara Morin. I'm a pediatric radiologist at Cincinnati Children's, and I'm excited to moderate this webinar. We have three really excellent members of our Xenon team today who will be all speaking on different parts of our program, starting not actually in the order that they're speaking, but in the order they're on the slide. Dr. Paul Gillerman is a professor of radiology. Dr. Eric Heisinger is a professor of pediatrics in pulmonology. And Dr. Jason Woods is one of our lead researchers in xenon MRI and a professor in both pediatrics and radiology. So we're going to start off today with a poll on lung imaging with xenon MRI in children. What best describes your familiarity with xenon MRI and your reason for attending the webinar today? So if you don't mind, just go ahead and answer this one for us. I think just have to move it out of the way for me. And just to give you a brief agenda, we're just going to start off with some brief background on the current state of pediatric lung diagnostics, move on to more information about xenon MRI as a biomarker, and then move into clinical program implementation, and then have a great set of cases, both from the radiologist perspective and the pulmonologist perspective, and then just a little bit of information on xenon MRI reimbursement, and then we're going to have time for questions and answers at the end. There is at the bottom of your screen a button that says Q&A with a question mark, and that is where you should put your questions in for the speakers today. The speakers will be able to see those questions, but not everybody, and we'll try and answer those as we go along, either directly in the chat or by answering them out loud. So we'll go ahead and end the poll. And then Alexis, can you end the poll and share the results? Okay, so if we just take a quick look at these, we have quite a number of people who are familiar with the basics and want to learn more, and a little bit fewer who are brand new to xenon MRI. I think we're going to have a lot to offer both of these groups. So we'll go ahead and get started. Okay. So if you're not familiar with xenon MRI, Polarean's product was FDA approved to assess ventilation defects in patients older than 12 years of age, December 28th, 2022. And here at Cincinnati Children's, we scanned our very first clinical xenon patient May 5th of 2023. And then the FDA expanded our indication to include children 6+ years in June of 2025. So we've been scanning patients for a little over 2 years now, and that is what a lot of this experience that we're describing today is based on. If you just take a little bit of a step back and talk about how we currently assess children in radiology, that has predominantly been through CT scans and scintigraphy. As everyone knows, in pediatric radiology, we try to image gently and use radiation as infrequently as possible in order to answer clinical questions. Spirometry is also very effort dependent and insensitive to detect small differences. So in children, this can be a major limitation in some groups. So that's where XenoView comes in, or xenon MRI scans. You can see from the picture here, that's one of our research technologists who's administering a dose to a patient, and it is in a bag. You inhale it. It's a single 10 to 15 second breath hold. I will say most of our children can do this, and Dr. Gillerman will talk more about this as well. There's no radiation exposure to patients, and it has been in use with patients greater than 6 at our institution. You can see these adverse reactions also in the package insert. The main adverse reaction that we have seen is, it's not really an adverse reaction. I would say the main side effect that we see is a little bit of tingliness and your voice changes. I think Dr. Woods will also go more into that. In the published literature, there are some data that support that there's a transient decrease in oxygen saturation. And so we do monitor pulse ox for all patients. So what does xenon MRI look like? Essentially, you have the patient inhale the xenon gas, and then it fills the lungs, and you can see everywhere that the xenon goes. And what we're looking for, in this case, are ventilation defects. So areas where you don't see the xenon going, and those really just show up as black holes in the imaging. And so you're just looking at where the xenon is following the same path as oxygen. And then if it's not there, then you'll have a black hole, and that's considered a ventilation defect, and we can quantify that. It's also really important to note that this is a 3-dimensional acquisition. And so unlike SPECT CT, where we really are getting a bunch of 2D planar images, and we do some attempts at quantifying perfusion defects. It's not the same sort of spatial resolution that we can get with the 3-dimensional xenon MRI, where you can see some examples, and you'll see a lot more later, where we have really precise quantification of the ventilation perfusion defects. And in this case, this is just an example from one of Polarean's collaborators or an early adopter, Dr. Eddy in British Columbia, of a patient with asthma, where you can see perhaps subtle changes on the CT, and the xenon, you really bring out that functional defect. It's much more obvious, and it gives us that quantitative functional information. So I'm going to go ahead and pass it along to Dr. Woods, and he'll take over describing how more in depth how xenon works and how you can implement it in clinical practice.
Thank you very much, Dr. Marin. We can go ahead and go to the next slide. I wrote a review article last year, and I entitled it Lung MRI, the Future is Now. And that's really what I think. So the emphasis of this article is simply that we have all the tools available right now to sort of see the future, and that is to do functional lung imaging via xenon. Importantly, in all obstructive diseases that we've investigated, we see observable abnormalities. So these are examples, 3 examples in asthma, in PCD, that's ciliary dyskinesia, and cystic fibrosis here. And these are just 3 examples. But in each of these cases, and in all obstructive diseases that we've investigated, we see abnormalities. And you click on the next thing. So VDP, which Dr. Marin mentioned, is actually ventilation defect percentage. It's an intuitive measurement, and I have a slide next for that. So the way that we calculate the VDP is simply a volume fraction of the amount of the lung that's below a certain threshold of ventilation. So we ask the computer or ourselves to denote those areas that are dark in the image, and we call those ventilation defects. We simply calculate the total lung volume from proton scans, and then the ratio of those two is simply the ventilation defect percentage. So in this particular case we're looking at, it was 36%. And importantly, the xenon MRI, in a lot of our research experience, reveals regional obstruction in a way that is simply beyond PFTs, that is more sensitive than PFTs. And to illustrate that here, I'm showing you a reference from some of our published work in 2019, where we have 3 different patients here. The top patient, or all three patients, are post-bone marrow transplant, and they have approximately the same spirometric values for FEV1. So if you click through, the top patient is very, very uniform, almost no ventilation defects. And so by volume, this was 3% of the lung, so basically normal. The second patient, you can see, is considerably different from the first. So small, subtle defects around the pleural surface, little wedge-shaped defects throughout the lung. And that was 19% VDP. And then the patient on the bottom has a couple of larger defects. And all of those are very different kinds of phenotypes. But the top one is very uniform ventilation. The bottom two are very non-uniform ventilation, all with the same FEV1. So this is my view of what is important for an imaging biomarker. So sensitivity, sensitivity, sensitivity. So sensitivity is important, but we also need low same-day variability, and we've demonstrated that in a number of single-site studies and a multi-site study that was published last year, that indeed that we have low same-day variability, roughly 1%, and in CF lung disease it's closer to 2% because there are some mucus plugs that move around in CF. It's important to be able to see disease progression. That's in the center. So here I'm showing you a case in CF lung disease, baseline at the top, and then follow up about 2 years later, and we see significant disease progression, which we expect in cystic fibrosis, and we see treatment response. So there are some fairly famous set of images on the very right. This is helium-3, not xenon, but this is ivacaftor before treatment on the top and after treatment on the bottom, and there's an enormous change. So it goes from 48% to 17%, but the visual change is really obvious and stark. And then very subtly is the left-hand case where we see a baseline of 17% VDP, and that changes to about 14% VDP after treatment. This was for lumacaftor, ivacaftor, and so that's a very subtle treatment response, and we can see that treatment response via xenon. And importantly, we can predict and use this as a measure of future exacerbations and clinical outcomes. This is simply a demonstration from our group in severe asthma and pediatrics, but the same kind of thing has been shown in adult diseases and COPD and in severe asthma. So in the highlighted sections here, I'm showing was xenon predictive of any healthcare utilization, the rate of healthcare utilization, the rate of oral corticosteroid use, and the answer statistically is yes, with a correlation coefficient that's not quite perfect. It's about 0.5, but a p-value that is 0.05 or below, and this is in a fairly small number of patients, 21 patients. And importantly, it predicted long-term quality of life improvement. So this is work from Marissa McIntosh and colleagues, simply showing that the MRI VDP independently predicted quality of life by asthma control questionnaire after 2.5 years. So the VDP is indicative of the clinical nature of disease itself and treatment response and quality of life. So MRI diffusion-weighted imaging can also demonstrate and measure alveolar airspace size. So this is a cartoon representation where I'm showing some normal alveoli on the left. And so the xenon is simply restricted by collisions with those alveolar walls. So the ADC, or the apparent diffusion coefficient that we measure, is much lower. And in a case to the right, where there's a little bit of alveolar simplification, as we would call it in pediatrics, so enlarged alveolar airspace sizes, the ADC, or the total amount of movement of the xenon within the alveolar spaces, is indeed larger. And so this has been shown translationally in bronchopulmonary dysplasia, where we're seeing all manner of abnormality. So ventilation defects on the left, alveolar airspace size increases in the middle, showing an increase that's not quite a factor of 2, but a significant increase in alveolar size. And then also abnormalities in gas exchange, which I'll show you in just a moment. So it turns out that ADC is a very quantitative biomarker of alveolar airspace size enlargement. This has been shown in multiple studies. Here we're highlighting one from our group where we've seen increases in both VDP and the ADC, the apparent diffusion coefficient in BPD, and the amount of variability is actually quite large among these patient groups. And so there's an individual personalized medicine aspect that can be realized. So there are additional properties of xenon that are being explored on the research side to understand gas exchange in the research setting. This indication for xenon is not yet FDA approved, and we're hoping that that will be FDA approved in the next few years. So there are unique properties of xenon in the sense that it's a large atom, it's a large molecule, so to speak, and it dissolves ever so slightly in tissue and blood. So if you click the next slide, there are three compartments here. So in an NMR spectrum, xenon can be seen in the air spaces, that's blue, in the interstitium and plasma, those are what we call membrane tissues, and so that's in the tan color, and then separately in the red blood cells, which is red. So there are three NMR peaks that we can then separate and use to generate images of those three distinct spaces. And these are demonstrations of each of those: ventilation on the top, membrane in the middle, and red blood cells on the bottom in a healthy patient, in a COPD patient, an IPF. This technique was begun in adults, and so the demonstration of the utility of the technique is fairly well established now in adults. So in the COPD patient, you see, of course, ventilation defects, some actual reductions in membrane, which is indicative of emphysema, and then a reduction in the red blood cell transfer, which is also indicative of emphysema. In the IPF patient, you see roughly normal ventilation. Ventilation is not significantly affected in most interstitial conditions. And then in the membrane signal, you see a significant increase. So with significant fibrosis and inflammation, we would expect that the xenon is deposited a little bit more, more densely in the interstitium. And then the red blood cell transfer is significantly affected as well. And there's not a one-to-one correspondence between the RBC and the membrane. So those areas of increased membrane are not necessarily the areas of decreased RBC. So in terms of workflow and practicalities, we certainly need a hyperpolarizer and a hyperpolarized lab. We have to plan the dose, communicate with the MRI operator because we don't want that signal to simply be sitting around for too long. It has a lifetime or a T1, of 30 minutes or an hour in our fringe field or in our holding field. So what we need to do is simply prepare, communicate with the operator that the patient is ready for the dose, and then deliver that to the MRI suite. And on the left, I show you a typical lab setup with a dose that we typically say should be less than a 5-minute walk. So it doesn't have to be directly next to the MR scanner, but it needs to be close enough so that we can walk it, within about 5 minutes. And so in our particular clinical operation, it is indeed about a 5-minute walk from the hyperpolarized gas to the clinical scanner. Next slide, please. In the MRI suite itself, we simply position the patient. So I have a volunteer on the left showing you the vest coil in purple. So it's a little bit like a life vest preserver, and that coil covers all of the lungs. And then you see the gas delivery in the bottom right of that. So we have some clinical support staff. We fit the chest coil to the patient, administer the dose, and then start the imaging. The breath hold can be as short as a few seconds and sometimes as long as 15 seconds if it's a very large patient or if we're doing a complicated sequence. Next slide, please. And if you click on this video, this shows how xenon is actually, the xenon ventilation sequence is integrated into the Philips MR 7700. So this has been really good for us because it's been much more plug and play than we anticipated. So that integration into the Philips machine has been pretty flawless, and so When we started that with our new scanner, it simply went off without a hitch. And next slide, please. So one of the other thing that Philips has done is to use AI reconstruction, which they call Smart Speed Precise. And here I'm showing you two different examples, a healthy patient or healthy volunteer on the top, and then a patient with significant lung abnormalities on the bottom. You can see these ventilation defects. And the precise reconstruction simply makes the images a little bit crisper and easier to read and identify the defects. So in terms of implementing a new clinical program, I've listed three buckets really. So we need infrastructure and equipment, we need the team and to work out the workflow, and then reimbursement and financials. So on infrastructure, you need a scanner. Typically this is 3T. The manufacturers are supporting multinuclear at 3T, and that's the reason I mentioned that field strength. Multinuclear capability is obviously important, and then the sequences that come with that. One needs a hyperpolarizer and a lab, and then the xenon coil. So not too many elements, but a few elements are important to move forward with the infrastructure side. On the team, you need a radiologist or a team of radiologists to actually be able to read the images. We started at our institution with people who read nuclear medicine scans, and then that moved to the chest section as people got more familiarity. We need referring physicians like Dr. Heisinger, who's on the call, MR techs who are familiar with the sequences, and then a workflow for scheduling, gas delivery, and monitoring. On the reimbursement side, we need to understand what billing codes actually apply. And so we and other institutions have worked out some of that in collaboration with Polarean. You need to work out what your volume expectations are, so you don't get too many patients in the beginning or too few. And then payer coverage and estimated payment rates, which relate to return on investment. And to Dr. Gilliman.
Okay. So I'm going to talk a bit about some of our clinical cases that we found instructive and give us an idea of the scope of applications that are possible with the xenon scanning. So next slide. Okay, and as with Jason, I'll be touching on some of the off-label applications as well as the ventilation, such as gas exchange and diffusion-weighted imaging. Next slide.
Paul, I think we are going to go ahead with the next poll.
Okay.
So if folks want to answer the question that should have popped up on your screen, which areas would your team benefit from the most support with when preparing for a Xenon MRI program? And this one will save the results till the end. So go ahead, Paul.
Okay, so as was mentioned earlier, we started scanning our clinical cases back in May 2023, soon after the FDA approval. We currently we allocate 2 slots a week on a particular day, so that way the logistics can be coordinated the best instead of them just being randomly scheduled. We're up to close to 100 scans now that we've done, and we have quite a broad age range, although the focus of this seminar is on the pediatric population. We're the only institution in the area that can perform these studies currently. And so we've also had a number of adult patients as well that have been scanned. The most common indications are ventilatory diseases, which is intuitive given the ventilation scan. So obstructive lung diseases. We have a pretty large post-transplant population that is at risk for bronchiolitis obliterans. So that's a large number of our cases, but it really spans the spectrum of ventilatory diseases. We also receive referrals for patients who, despite extensive workup, still have unexplained shortness of breath. And so the idea is this may give some clue to what's going on in possible treatments. In some cases, it's been valuable in terms of instructing patients and their families what's actually going on, because they're visual representation of what's happening in their lungs. And sometimes that works a lot better than words, showing actual pictures. And then another indication that's really taking off for this is to help plan interventional bronchoscopy procedures. And Eric, who's our next speaker, will be going in more detail about that. So next slide. And so the way we do these studies, it really is a team effort. We have the so-called barista who will prepare the xenon. And then we have a couple of technologists that will coordinate with the instructions to the patient so that the compliance is improved with it. And for safety reasons, we have a nurse that's going to be monitoring the oxygen saturation levels and vital signs during the study. We base the xenon dose on the size of the patient in quarter-liter increments based on the patient's height. And then we acquire our proton image for the anatomic detail that's needed for calculating the lung volumes. And then we proceed with the xenon ventilation study. And then we followed up with some more anatomic and pathology-based sequences. We do a UTE scan, and then we also do a couple of T2-weighted sequences as well. And so the images that are reconstructed, since historically ventilation was imaged with nuclear medicine studies, the images that just show the xenon distribution look reminiscent of the nuclear medicine ventilation scans, but there's much more signals, so you have more anatomic detail. Then we have the overlay of that with the anatomic scan. And then we do a color-coded map that's divided into bins on the severity or the degree of ventilation in different lung regions, which really makes, let's say, underventilated areas stand out. Different institutions use a different metric for what's actually the threshold for calling a ventilation defect for calculation of the VDP. What we do is we normalize it to the 99th percentile voxel, and then when it's under 20% of that, it's put in that bin that we use to calculate the ventilation defect. We don't include the central airways for that calculation, so it's really focusing on the alveolar space for that calculation. Next slide. And Jason showed this slide earlier, so we have that initial proton anatomic that's going to be sequence that's going to be used for the volume to help calculate the VDP. Next slide. And as far as how do these studies turn out, the vast majority are of at least adequate quality to answer the diagnostic question that's been posed. In about 10% of cases, they've been limited or non-diagnostic. Some of these are technical issues related to either issues with field inhomogeneity or issue with the coil. But the most prevalent issue is, in particular, in very young patients. It requires cooperation to hold their breath long enough to acquire the scan, so 10 to 15 seconds. And so if they exhale before that acquisition is complete, it's going to decrease the signal in the lung. Next slide. And so this is an example of such a case. This was a 7-year-old who had juvenile idiopathic arthritis-related lung disease. And you can see the red outline here of the lungs based on the anatomic image sequence. And you can see the signal that is external to the lungs in the space around the patient. That's the exhaled xenon. So this is what happens if they can't comply with the breath hold. But prior to the study, there's a rehearsal done with the patient to try to improve compliance with that. Next slide. And we generated a structured report, so that way there's some consistency and standardization of how we give the information to the referring clinician. And so this is an example of our template. We go through the findings, and then there's some quantitative metrics in terms of the VDP, what lung regions are involved, and so forth. And then we also had those anatomic sequences, the UTE and the T2, so that way we may not miss some incidentals that may be clinically relevant that are independent of the ventilation itself. And so here's a case here. This is one of the more common indications. This is a patient who had a bone marrow transplant, so they're prone to getting graft versus host disease and bronchiolitis obliterans. And so 12-year-old in this case. And you can see the areas depicted in red on the color-coded maps that are the most profound ventilation defects, very extensive defects in this particular patient. Next slide. And so in this case, it was quantified about 40% of the lung had that threshold of being at the lowest level of ventilation. And next slide. And so this was due to bronchiolitis obliterans. And our conventional, traditional way of assessing this is to do inspiratory, expiratory chest CT. And so you look for areas of air trapping on the chest CT that are hypoattenuating regions of the lungs. And there's a pretty good anatomic correlation with what you see on the xenon with the CT. However, the xenon, if you look at those areas that are color encoded at the most severe ventilatory defects, they're a bit more extensive than what you can see on the CT that was obtained concomitantly. So inferring from that the ventilation xenon study is going to be more sensitive to areas of ventilatory defects or air trapping than is the conventional CT. Next slide. Here's a similar case, another bone marrow transplant patient who has graft versus host disease. And just by looking at the color encoded map, you can see just how extensive these ventilatory defects are in this particular patient. Next slide. And despite that, though, their PFTs didn't take a sharp decline until about 7 months after the MR was obtained. So again, underscoring that while pulmonary function tests or a more global assessment of lung function, the advantage of the xenon scans, they may, in addition to being more sensitive, give you a more regional depiction of what's going on. So there may be pretty significant involvement of portions of the lung that don't show up on a conventional pulmonary function testing because it's a global measure. Next slide. So here's a patient who had an immunodeficiency that as a result of that was prone to get recurring pneumonias. And you can see with the arrows showing these very sharply delineated ventilation defects at the lower lungs. And you can see the corresponding CT image with that. This particular disorder, they also are very prone to getting bronchiectasis. And on the CT, you can see that collapsed left lower lobe. That on the ventilation image for the xenon shows very little actual ventilation. And if you go on to the next slide, so this patient had follow-up. So the problem with many of these patients, they would be getting numerous follow-up CT scans to evaluate the progression of their lung disease, which of course imposes radiation exposure, which we like to avoid in children. And this is showing a xenon study that was done a little over a year after the initial one. And you can see that progression in their ventilation defects as a result of their airways disease from their recurrent airway infections. And again, a method to do serial surveillance of patients without evoking or imposing radiation exposure on them. Another case here, this was an asthmatic that although it was bronchodilator responsive, the patient was not clinically as well as you would expect with their treatment. And so they obtained the xenon scan and you can see pretty extensive ventilatory defects. And so this underscores another value of this is that if a clinician has prescribed a treatment regimen for a patient, often they're making the assumption they're following that therapy. And so in this case, they at least had been demonstrated on pulmonary function testing that they were bronchodilator responsive, but you can see from the xenon study that indeed they still had pretty extensive ventilatory defects. So next slide. So this is an illustration of how it can be valuable to show, or at least you can infer from the study whether or not they're actually complying with their therapy. At the same time, you can imagine how dramatic showing this is to the parents to say, this is what's happening if you're not following the therapy that's been prescribed. Next slide. Here was a case, I mentioned earlier that one of the areas that we see a lot of growth in indications for ordering these studies is for planning of interventional bronchoscopy procedures. So this is a patient that had a very hyperinflated right upper lobe and also had volume loss in the right middle and lower lobes. And the consideration here is whether or not this patient should undergo placement of an endobronchial valve to reduce the hyperaeration of the right upper lobe. And so the question is, how well ventilated is that lobe compared to others? And so you can see on the xenon imaging a markedly hyperexpanded right upper lobe that has, it's fairly subtle, but it has less ventilation than, for example, the normal left lung. And you can see that actually the right middle and lower lobes, which are somewhat compressed and have volume loss, actually have more ventilation than that right upper lobe. Next slide. And then moving on to a topic Jason had mentioned is that when you look at do the diffusion weighted imaging or the diffusion imaging, you can see that in the right upper lobe, the average alveolar sizes are much larger. So these are enlarged alveolar air spaces that's been revealed by the diffusion imaging. And then furthermore, the next step, looking at the gas exchange, there's impaired transfer of the xenon from the alveolar spaces to the blood pool and the red blood cells. And so one of the causes of that would be if you have diminished capillary network in the alveolar wall, so there's impaired gas exchange. And so this is really fitting to a condition like congenital lobar emphysema, in which you have a very hyperinflated lobe of the lung, but in which the alveolar air spaces are very enlarged and you have a decreased capillary network within that. And Eric's going to be talking more about this particular case in his presentation to come. Next slide. Another one that will be touched upon by Eric as well is this case. Very recent, we had a 15-year-old who has an immunodeficiency where they develop recurrent staphylococcal infections. This particular patient had a huge nematocele in the right lower lobe, which extended almost up to the apex of the right hemithorax. And so the right lower lobe was resected to improve lung mechanics and ventilation of the right upper and middle lobes. However, the patient developed persisting air leaks, and endobronchial valves were put into the segmental bronchi in both the right upper and lower lobes. In addition to that, they put a fibrin and blood patch in the right lower lobe stumps, but they were still having air leaks. And so the question was posed was, what is happening to xenon that's inhaled? Is it going to go into that right upper lobe, which it really shouldn't, since the bronchi have been plugged, or it shouldn't be retained in that lung or that upper lobe. So next slide. So what the xenon showed that, in fact, there was ventilation of that right upper lobe. And we also did a delayed imaging acquisition in which you can see that the xenon is cleared normally from the left lung, but it's still retained within that right upper lobe. Next slide. Another thing to underscore is that not everything that's a ventilation defect is going to be related to airway obstruction. And so it's important to correlate what you see with any anatomic imaging that's available. So here's a patient who had leukemia. And when you look at the xenon image on the left, you can see that defect in the right lung. And it doesn't have, let's say, the typical sort of wedge shape that, let's say, a plugged airway would show, more irregular. And if you go to the next slide, and you can see on our UTE sequence, as well as the corresponding CT, that in fact what this patient had was an aspergillosis infection in which they have a cavitary lesion in that region of the lung that was also leading to a ventilatory defect. But again, underscoring the importance of looking at the anatomic images as well. Next slide. And then another limitation I wanted to mention is illustrated in this case. So this is a very young patient, even though they were only 4 years old, which is below the current, so this is an off-label use here. They still did a great job of holding their breath for the study. You have beautiful ventilation images that were acquired, and really they're normal with the exception of a little bit of ventilatory defect in the retrocardiac left lower lobe from some atelectasis. But when you go to the CT that was obtained around the same time, which is on the next slide, you can see that this patient who's got systemic JIA has very extensive interstitial lung disease. And so that is something that if you do gas exchange, you may reveal some gross abnormalities on that, but yet they may have essentially normal ventilation. So again, underscoring the importance of looking at the anatomic images and also thinking about applications other than just the ventilation by using xenon. Okay, so in terms of disease categorization, I showed you in cases here, particularly bronchiolitis obliterans, where it may be more sensitive to conventional pulmonary function testing for early disease. And at the same time, it's a way to monitor progression of the disease or therapeutic response without using ionizing radiation. It can be very valuable for demonstrating to families what is happening with their child's lung disease to help improve compliance with therapy. And then the next step, of course, which I see as a very prominent future indication, is going to be helping to guide interventional management of these patients with these advanced bronchoscopy procedures. And so Dr. Heisinger from our institution will then be taking over to talk more about that.
All right. So thanks very much. And yeah, I think there's some really nice opportunities to, in addition to looking at our more traditional pediatric lung disease, to really be able to look at some of the advanced techniques that we're using endoscopically that's starting to grow, and then combining with some of these advanced imaging techniques and see if we can spare some kids some much bigger procedures with just better understanding of what's actually happening to them. So next slide for me, please. And I should just mention that I've received some speaker fees from Olympus that are somewhat relevant to this talk regarding the spiration valves I'm going to discuss. And when we're thinking about IP applications of using xenon, really we're focusing on the regional ventilation component of this. And are there areas that we either need to open up, or are there areas that we need to make shrink? And those are sort of our two fundamental things that we can do. We can make it bigger, in particular with bronchial stenosis that can come from autoimmune disease. It could be infectious. It could be traumatic from suction or intubations, inhalation injuries. We'll see it in some of our transplant patients, idiopathic. One population that seems to be coming up a lot in the rheumatologic area has been our GPA kids, but they can have some really pretty prominent diffuse bronchial stenosis that we need to work on. We can make those bigger, or the other option is we can make it smaller. Lung volume reduction for COPD. We're looking into the lobar emphysema that was alluded to earlier. Although I apologize, I'm not going to share that patient for time's sake today, but we'll look at two other cases. Persistent air leak, and then also I'm particularly interested in, can we look at this in BPD, but that's going to be something that's going to be in the future to come. Next slide, please. So if we're managing our stenosis, just three things that we can really do that we're leaning on. We can freeze it, we can fracture it, we can fry it. And with trying to fracture it, balloon dilations can crack open scar bands. Freezing it, we'll use cryotherapy to devitalize scar bands and help shrink those up and prevent them from reforming. We also are using more and more electrosurgery so you can cut through the bands to create more and more space. And just an example coming up of where we've used this before. This is a young boy who came to see us. He was 12 at the time. He had granulomatosis and polyangiitis, had profound obstructive lung disease. I think his FEV1 was around 25 or 30% when we first met him. He was wheelchair bound and really not doing well. He had a local bronchoscopy that found that his right upper lobe was completely obliterated. And then he had concurrent right upper lobe atelectasis on his chest x-ray. Next slide, please. So we took him back to the OR, and he didn't just have right upper lobe problems with being obliterated. You can see that in that upper left bronchoscopy image, the little membranous occlusions of all the segments of his right upper lobe. His right middle lobe was down to a pinpoint. His right lower lobe, as it turned out, was really quite dilated. And we later discovered that it was bronchiectatic. His left main bronchus had a sort of a helical scar band that you can see here that was very, very thick. His left upper lobe, down in the bottom middle, had been narrowed down to about 2 millimeters, and then he had another occlusive membrane of his left lower lobe. So did very extensive bronchial stenosis for this patient, and certainly explains why he was quite short of breath. Next slide, please. So the first thing we did for this young man was we took him to the OR and we tried to open up the right side. We focused on one side so that we didn't run into potential problems with bilateral pneumothoraces. They tell me that that's a bad thing. And we ended up recannulating blindly those occlusive membranes in that right upper lobe using a combination of a needle, a wire, and a balloon. Unfortunately, because it was all atelectatic behind it, we didn't know whether or not this was going to be healthy lung. And when we opened up that lung, he ended up actually developing a pneumothorax. Once he recovered from that, though, he felt significantly better, but was still fairly short of breath. And so then we had to decide, what are we going to do about that left side, particularly that membranous occlusion of that left lower lobe? Next slide, please. And a question that I had for, in particular, in that left lower lobe that was completely occlusive was a few things. One, is that area going to be enough ventilation defect that was going to be worthwhile? And then two, is there any evidence of lung that's going to be useful beyond that? And so I reached out to at the time of the research group that was doing the Xenon and asked, can you help me understand the answer to this question? And it turned out that the left lower lobe, that superior segment, actually accounted for about 28% of the ventilation of the lung on that left side. And with that, we thought, well, that's probably going to be something that's worth trying to look at. And what we could see both from the combination of the MR and the CT scan is it looked like it was going to be reasonably healthy lung behind that tissue. Next slide, please. Also very important with this case, that particular segment, that superior left lower lobe, it was nestled right in between the pulmonary artery and the descending aorta. You have about 3 or 4 millimeters between the two. So trying to poke a hole in that area was something that was going to be very concerning for me to see if we were going to get into some trouble by putting a needle into some big vessels. So we wanted to be quite confident that there was going to be some worth of getting that airway opened up. But with the Xenon data and also how he was doing clinically, again, we thought that that was going to be worth trying to do for this young man. Next slide, please. So with that, we did end up recannulating that as well as opening up the left lower lobe. And one of the things that was really nice, you can see it in the PFTs on the right, you can see the increase in the FEV1, but you, in this patient, had several conflicting things. One, the right upper lobe was completely down, the right lower lobe was all bronchiectatic, and the Xenon gave us a very nice ability to see the regional changes going from the left side to the right side about areas that we had opened up. And in particular, if you look at the bottom here, you can see in the superior left lower lobe, where the blue arrows are pointing, before we had opened up that space, there really very little to no ventilation. And then once we had opened up that space, had very significant improvement in the ventilation. And it turns out that once we had gotten this particular area open back up, he got back to playing basketball and was living his life. And now, quite frankly, his biggest worry is who he was going to take for his prom date. So this has been a really nice combination of both some advanced bronchoscopy techniques and then also some of the advanced imaging techniques. Next slide, please. Now that was an example of where we can try to make things bigger, but we're about where we try to make things smaller. And we have two ways, or we have main way of doing this is going to be using endobronchial valves. There's two that are out there. I'm just going to show these for some brief understanding of what we're doing here. Zephyr valves, which we don't really use, the spiration valves, which we're using a lot more of in Cincinnati. And what they essentially do is they occlude the airway, and they can allow diseased areas of lungs that are hyperinflated or simplified to collapse so that other areas can expand and take up the space. Next slide, please. So when we're doing this, first we'll go in and we'll size the airway. There's a sizing balloon here on the top right, just so that we know the size of valve to place. The valves come in 4 different flavors. There's a 5 millimeter, a 6 millimeter, a 7 millimeter, and a 9 millimeter. Once we've sized it, then the valve can go in. It's demonstrated down in the bottom right panel here. And it looks kind of like an upside down umbrella with a little grasping bar that pokes out a little bit. And then there's the legs that kind of go in further into the airway to help hold it into place. Next slide, please. And an example of what will happen on a chest X-ray, this was one patient where we had placed a valve to do simulated endoscopic pneumonectomy because she had significant VQ problems and was not a surgical candidate because of all of her other morbidity. But on the chest X-ray, a little bit hard to see it. The valve is highlighted on the right side, and you can see the pretty rapid collapse of the lung, both pre-op and post-op. Next slide, please. The area where I think we've been having more success is really with trying to use persistent air leaks for this placement. And this goes back to this patient that Dr. Gilliman was presenting earlier who had a very large pneumatoceal. And I'll highlight a couple of things about this I think were very relevant for the surgical advancement of this patient is that pneumatoceal actually herniates posteriorly across the midline, abuts right next to the left lung. It sits right next to the right middle. It also kind of gets up into the right upper lung. And this thing was just massive. So when the radiologist when the surgeons were taking this out, we were all very concerned about getting problems with persistent air leaks. And then one of the real challenges is if we're getting air leaks, where the heck are they going to be coming from? Because this thing actually touches pretty much all aspects of the lung on both sides. Next slide, please. So we had been working on this child, and I really give credit to Dr. Greg Berg, is one of my colleagues who this is his primary patient, and he said I could share some of the information about this patient. We're seeing on the bronchoscopic image on the top left, this is the right upper lobe. You've got some of the valves in place in the apical segment. That's really the one that's most close up. The anterior and the posterior are the bottom portions of that top panel. The stump of the right lower lobe was on the bottom left, and then the right middle lobe, the medial and lateral segments, all appear to be really well occluded. This child has been through several valves, has been through blood patches, has been through pleurodesis, has been through any number of things trying to get this to stop. We had not been able to get the air leak to stop. And at this point, we were looking towards, we just need to do a full pneumonectomy, even though there was actually a decent bit of viable and healthy lung tissue. But before we did that, we said, hold up, let's reach out and see, is there an area that is still getting ventilation, even though looking at this, nothing should be functioning. The middle lobe is out like it should, or when we got the ventilation, we found that the lower lobe was not functional as it should be. The middle lobe was not functional, but lo and behold, that right upper lobe was still getting ventilation. So we brought the patient back to the operating room and took a look again. Next slide, please. And with that, when you first look on the left-hand panel, it looks like everything is positioned reasonably appropriately. The apical segment looks to be occluded, as does the anterior and the posterior segments of the right upper lobe. But then when we took a little bit more investigation and looked a little bit more carefully than we otherwise might because of the information from the Xenon scan, what we saw is that there's actually this very small little gap, and you can see it on the right bronchoscopic image. There's just a little bitty hole that's there. That hole may be a millimeter, but it's enough that air was getting through, and that was where our air leak was coming from. So we ended up redoing a patch on that, replacing a valve on that. And following doing that, she was actually able to get to a Heimlich valve and then just actually had her chest tube removed recently. And I think the big thing for her is she was able to be spared a pneumonectomy because of the information that we obtained from this combined with the advanced bronchoscopic techniques. Next slide, please. But from an IP standpoint, I think there's several options for us to be able to learn from Xenon with regards to regional ventilation about how we're going to guide our IP procedures, either for dealing with stenoses or obstructions, or also trying to do lung volume production. Did not get into this, but there's going to be, I think, some implications from the ADC in particular about dealing with the problems with the expansion pneumothorax. And the whole goal of all this is to remove the largest foreign body that can be removed from the airway, which is the thoracic surgeon. I think that's all I've got for me. So I'll pass it on to Dr. Moore.
Yeah, back to me. Thanks, everybody, so far. We just have a couple of quick slides, and I would like to have some time to run a final poll, and then have some time for questions. So, Alexis, are you going to start the poll now? I might have closed my poll screen, so I can't. Oh, there it is. Okay. So our last poll that we're going to have is, what do you find most compelling about Xenon MRI? Hopefully you got to see a lot of the compelling uses that we're using it here at Cincinnati Children's. And we are really excited about this technique and what opportunities it offers. While you guys are answering that, we'll just go through a couple slides on reimbursement. So the Xenon is a little bit complicated in terms of reimbursement codes. There are actually 5 CPT codes that we bill for every Xenon MRI. So there is a code for the gas. There's a code for the MRI with the gas. There's a code for MRI chest without contrast. So that's just our regular anatomic imaging. And then there are 2 codes for the quantitative post-processing piece. And the monetary values here that you see are estimated values from CMS. They are not what we're getting across the board on all private and public insurers in Cincinnati. But these are the 5 codes. I think, Alexis, there's one more slide. And I guess, so just some insights about reimbursement. Our ordering physicians have primarily come from pulmonary cardiology and oncology. We do pre-authorization as needed. Not all insurers require it, but if they require it, we're doing pre-auth the same way that we do any other MRI procedure. We did generate, when we started this clinical program, some pre-made letters that can help with the pre-authorization process and can be submitted as needed for each patient. And we have been processing claims from the beginning. So over 2 years, we've learned a lot during that process. And we have been getting increasing reimbursement through that time. And we have some data on that, but it was not available for this talk. I think that's the end of our slides. And so we did want to move on to a live Q&A. We have been answering questions as we go in the Q&A box. So I think you should be able to see the answered questions in that box. But otherwise, if anyone, I think at this point, would like to unmute and ask a question, you can do that. So here's an interesting question that can go to everyone that just popped up in the Q&A from a UK-based investor with a real interest in xenon MRI. So we talked about how we don't recommend using radiation-based CT scans for children, and therefore, do you feel over the next few years all lung pediatric hospitals will take up xenon MRI for the pediatric patient? I think that's a complicated question. Who wants to start? Jason, you look like you're excited.
Well, it obviously is a complicated question, but my answer to the question is that it will see broad adoption slowly over time. That the large academic medical centers, have adopted this first, and we are seeing expansion of those large academic medical centers. And my suspicion is that when it slowly continues to catch on, that the referrals will come from more regional hospitals to academic medical centers, and then that will expand to medical centers that are maybe in between the large center and the regional medical center. So I just see a slow growth that's somewhat linear or slowly exponential.
Dr. Gillerman?
Right. I look at it as kind of analogous to, let's say, MR elastography. What starts out as a niche application, once the clinicians get used to seeing it, they move to other institutions, and then they encourage their local institution to adopt it. So it's just sort of in the, I guess, the early growth phase right now. But as the indications spread and people become aware of it, it'll be increasingly adopted.
And Dr. Heisinger, do you see us getting rid of chest CT?
Well, I don't see chest CT going away because it's quick. It's quick and it's ubiquitous. But one thing I think that's going to be really important with this, and I can't overstate this, is there's information that you can get from the xenon scans that I simply can't get from the CT scans when I'm patient facing. I can get some potential guesses, but I can't get the same information. So having a more complete perspective, a complete understanding of the patient and how they're functioning, as opposed to and how they appear, really can help guide therapy. Another barrier that I'm seeing right now is that a lot of the pulmonologists, they don't understand what they're looking at. There's even within our own institution where we work on this, is people don't necessarily understand what all these things mean when they're the clinicians that are facing the patients. And so education for people to better understand what these metrics are and how they can inform patient care, things can be very useful to trying to move things forward. Because right now, pulmonologists or cardiologists are very familiar with the CT scans, but the xenon is still a very new thing to most of the direct patient-facing providers.
Yeah, thank you. I think we are up at time, so that's going to be the only question that we can answer live. You can continue to put questions into the Q&A, and we will try and answer them afterwards. You can also reach out to any of us at Polarean or at Cincinnati Children's, and we're happy to answer continued questions as we go. Thank you so much for attending.